البث المباشر ابتدى. تفضل يا بروف.
السلام عليكم. أنا خلف الله بشارة، أستاذ مخ وأعصاب بجامعة مينيسوتا الأمريكية، والليلة حتكلم عن مضاعفات الجهاز العصبي في COVID-19. I'm just going to share my screen. The COVID-19 in most cases present with the things that we know, fever, sometimes respiratory symptoms, but if we consider headaches as a neurological problem, is pretty common. Headache, dizziness, and so on. However, it's important to know the symptoms that can be the actual first symptom or the actual presenting symptom. And in COVID-19, there are a few neurological symptoms that can be actually the first symptom, and even COVID-19 may not be suspected because the presentation is neurological, is different. These include things like encephalopathy or drowsiness, sometimes seizures, loss of smell or anosmia or loss of taste, or present with strokes or cerebrovascular accidents or cerebral infarcts, or encephalitis or meningitis or meningoencephalitis. There is also some rare cases of presenting with typical Guillain-Barré syndrome, weakness of the legs and tingling and so on. And we'll talk about this in some detail later. So the most of what we know about COVID-19, we have some idea from the MERS and SARS, MERS or Middle East respiratory syndrome, and SARS, which is now known as SARS, severe acute respiratory syndrome, coronavirus 1, because the COVID-19 is SARS coronavirus 2. So we know that these viruses or these coronaviruses do have some predilection or preference to infecting the nervous system. There are several theories how this happens. First, the virus enters a cell through the angiotensin converting enzyme receptor type 2 or ACE2. And these receptors are abundant on the endothelial cells, so the virus may gain access to the blood vessels and gets to the brain that way. Or through the blood vessels or the blood-brain barrier, white cells containing the virus may enter the brain that way. There is another direct mechanism. We know that the virus is concentrated in the nasal cavity, and it can go through the olfactory nerves, which are directly connected to the olfactory bulb, which is part of the cerebral cortex. And the ACE receptors or ACE type 2 receptors are found in many tissues, including the brain. And within the brain, they are abundant in the olfactory bulb and some other gyruses like the cingulate gyrus and so on. So the olfactory bulb itself does have enough ACE2 receptors to allow the virus to go in. The third mechanism is that the virus transmits itself from one neuron to another through transsynaptic transmission, which is a process of exocytosis of the virus, and then it goes to through the synapse to the other neuron. And this is how it gains access to other neurons once it's in in the olfactory bulb or the olfactory cortex. One of the symptoms that we can label as neurological is the anosmia, or loss of smell, and is often associated with loss of taste. Actually, loss of smell in general can lead to loss of taste. When you lose the smell, you have difficulty tasting foods and so on. You can tell probably between salty and not salty and sour and so on, but the flavor of the food is lost and people complain of loss of taste, while the problem is actually the loss of smell. This loss of smell symptom can be a true presenting symptom, like exactly the first symptom, that the patient will not have fever or cough or any other problem. They just complain of that they lost the ability to smell. And the studies so far showed a very peculiar pattern. In China, only 5% of patients reported this symptom, anosmia or loss of smell. While in Italy, they found that 20% of people have this symptom. In Germany, it's almost 90% of people reported loss of smell at some point. So it's very unclear why this variation of discrepancy between these populations. One theory is that the ACE2 receptor concentration itself is different from one population to another, and depending on the genetic makeup and so on. It's also possible that it's just the researchers in China and Italy did not ask the right questions or ignore this symptom. But at any rate, it's a very distinct symptom and pretty characteristic of COVID-19. And it usually recovers within 2 to 4 weeks with the recovery of the other symptoms. In one case, they actually, this is a 50-year-old woman who presented with loss of smell as the only symptom. And they did full investigations, ENT, nasoscope, and so on. And eventually they did an MRI scan, which did show change of signal in the olfactory bulb or olfactory cortex. This is these are FLAIR sequences, MRI sequences, showing there is this white signal compared to the rest in the olfactory bulb. Actually, it's present bilaterally, but more visible here on the right side. On this coronal section, it does show the signal in both on both sides. There are also there's also some change in signal in the gyrus rectus, which is in the front from the olfactory bulb. Anyway, these changes disappeared after 4 weeks, and at that time the patient had no symptoms. So this case does support the fact that the loss of smell is related to a specific change or infection of the olfactory bulb. The other sort of peculiar syndrome with COVID-19 is necrotizing encephalitis. And the acute necrotizing encephalitis is a syndrome that we see mostly in children. And most cases were reported of Asian children in Japan, Korea, and so on. And it's extremely rare in adults. While in COVID-19, we have at least a couple of cases of acute necrotizing encephalitis. this is characterized by inflammation with an encephalomalacia or formation of holes. As we can see here in this sequence, there is the microhemorrhages or small bleeds, an inflammation of the thalamus bilaterally. And the thalamus can, when the thalamus is affected, this can lead to impairment of consciousness, and perhaps this particular patient was in coma or severely impaired. And after contrast, as we can see, there is some enhancement of the meninges, but we see here there is ring enhancement. This round after contrast signal the lesions within the thalami, or the right and left, the left and right thalamus, are ring enhancing. This is quite characteristic of acute necrotizing encephalitis, and we see it in viral infections. Typically, after like influenza infection, as I said, in children in Asia, mycoplasma or herpes simplex or herpes type 6, and it is thought to be due to either direct infection of the brain or as an autoimmune response to the viral infection. Prognosis is very poor in this condition. And then there is the regular or standard stroke. This is not very common, only 5%, and is more common in elderly, old age, and people with other risk factors such as hypertension, diabetes, hypercholesterolemia, atrial fibrillation, and so on. They found that people who had strokes in COVID-19 do have some markers like high white cell count, high C-reactive protein, D-dimer, ferritin, generally things that are showing there is a more severe inflammation or sepsis. The reason for having strokes, specifically in COVID-19, is thought to be related to hypercoagulability or vasculitis, inflammation of the blood vessels leading to these strokes. Anyway, the management of stroke in this case or in COVID-19 is standard management. There is nothing different. Once we have antiviral medications, maybe this will be added to the management, but the stroke itself is managed in a standard way, either by intravenous TPA, or if there are ability or facilities for catheterization and clot retrieval. If not, then the treatment would be, if there is atrial fibrillation, we treat with anticoagulants such as warfarin or apixaban, and is in other strokes we treat with aspirin and clopidogrel or Plavix as required. Sometimes hemicraniectomy is required if there is massive swelling from the stroke or massive bleeding and so on. With regard to coagulopathy, this seems to be a rather distinct, or not distinct, but I would say a common feature or a common problem in COVID-19. There is tendency to form clots, and there is also some tendency to bleed. The forming clots, it's a classical Virchow triangle. The blood vessel itself, as we said, the virus may enter the endothelial cells through ACE2 receptors, or there is injury to the endothelium of the vessels from cytokines or complement-mediated processes. There is also stasis. This in case of venous thrombosis, patients admitted to the ICU and they they should have prophylaxis against the vein thrombosis, either mechanical or low molecular weight heparin. Within the clotting factors, these do occur in COVID-19. There is elevated factor 8, elevated fibrinogen, which is inflammatory reactant and is increased in any inflammation, really. There are some circulating prothrombotic microparticles and neutrophil extracellular traps, or NETs. This the neutrophil extracellular traps, these have been described pretty recently in 2009, and are basically a mesh-like chromatin structures which trap the bacteria, and it can also cause clotting. They can be a reaction to cancer, to infection, and so on. And there is also hyperviscosity from increased proteins due to inflammation. And there is a condition that is actually similar to disseminated intravascular coagulopathy, or DIC. However, often the patients do not meet the full criteria for diagnosis of DIC. They do have low fibrinogen and the D-dimer, which is a byproduct of breakdown of the clots. So it indicates that clotting occurred somewhere. The D-dimer levels are high and are often associated with worse prognosis and other complications, lung and so on. But rarely there is severe thrombocytopenia or prolonged prothrombin time and so on to meet the criteria for DIC. Nonetheless, DIC should be suspected, and it's best to keep measuring these, whatever you have available, as far as if you have D-dimer, or even if you do a peripheral blood smear, the appearance of helmet cells or schistocytes is one feature of disseminated intravascular coagulation, and it's available by just microscopic examination of the peripheral blood smear. Most patients, or all patients hospitalized, especially those in the ICU, should receive low molecular weight heparin, but there is no recommendation for giving anticoagulants prophylactically in COVID-19. This is not well studied. There are some studies showing that people who received anticoagulation did better than people who did not. But every institution has its own protocol, and we should follow the protocol. The last thing I want to talk about is the Guillain-Barré syndrome, and this does not seem to be all that common. In a series of 1,200 cases, only 5 cases were reported, and in all cases, the presentation with weakness and tingling happens after 5 to 7 days from the onset. So initially they present with the typical symptoms: fever, anosmia, loss of ageusia or loss of taste, cough or pharyngitis, sore throat. And then 5 to 7 days into the presentation, they develop weakness of the legs, tingling, weakness of the arms, weakness of the face muscles, a typical Guillain-Barré presentation. It is important to recognize this as a problem in COVID-19, because rarely the patient may actually have the fever and other things and don't complain of that, and they just are alarmed by the weakness and present with weakness. As I said, it's not common, but since we have large numbers in thousands, it is likely that you will probably encounter one or two of Guillain-Barré as a presenting symptom. Clinically, in addition to the weakness and so on, there is areflexia, just like Guillain-Barré syndrome, and they may progress and deteriorate rapidly and require intubation and ventilation. So respiratory failure is a problem. There is one case of a variant of Guillain-Barré or the Miller-Fisher syndrome, Miller-Fisher variant, which is due to the same autoimmune problem, and there is weakness and areflexia, but in addition, they have ophthalmoplegia, weakness typically of the sixth nerve, typically bilaterally, and there is also cerebellar ataxia. So the process involves the cranial nerves, especially the eye movement, the nerves, as well as the cerebellum. And the Miller-Fisher is associated with this particular antiganglioside antibody, GD1B antibodies, if the test is available to confirm the diagnosis, although the diagnosis is really clinical, and this is just an extra. Just like Guillain-Barré syndrome, the changes in the cerebrospinal fluid is delayed, typically after the 10th day, and shows high protein and no increase in cells. However, the test for SARS-CoV-2 antigen or PCR and other methods was negative in all cases. So the virus does not seem to be present within the cerebrospinal fluid, which further supports the theory that the Guillain-Barré syndrome is a delayed autoimmune response, probably triggered by some molecular mimicry, that some structures in the virus resemble those in the nervous system or the peripheral nervous system, and that leads to autoimmune reaction and demyelination and so on. When they did electromyography, the findings were in most of these cases, 3 out of 5 or so, had the axonal variant of Guillain-Barré, with in addition to the prolongation and conduction velocity and so on, there is reduction of the action potentials indicating axonal damage. And some cases it is similar to AMAN or the acute motor neuropathy, involving primarily the motor fibers. The MRI in one of these cases did show enhancement of the facial nerves in the case where there is facial weakness, which is again consistent with an autoimmune inflammatory process. The treatment is again standard with intravenous immunoglobulins, sometimes in association with the steroids in some hospitals, but intravenous immunoglobulins is the first treatment, and if available, plasma exchange. Most cases required prolonged ICU admission and prolonged ventilation. So with regards to existing neurological problems like people with multiple sclerosis who are taking immune or disease-modifying medications, such as Copaxone, Avonex, and Tecfidera, and so on. Most of these medications are actually immunomodulators and are not immunosuppressant. And the recommendations now is to continue what they are taking at the same dose without changing or discontinuing any of the medications if they develop COVID-19. And it is also okay to use steroids if needed in patients with MS. In myasthenia gravis, the same thing. If they are taking any medications, immunosuppressants or others, they should continue without change. The only caveat here is that hydroxychloroquine, if used, should be avoided in myasthenia gravis because it does worsen the condition, the neuromuscular block. Epilepsy, as we said earlier, COVID-19 may present with epilepsy, or people who have epilepsy already, they may present with breakthrough seizures, some worsening of the epilepsy. And this actually happens with any febrile illness. There is an increase in seizures. So the management, again, no change in the medications that they are taking. All anti-epileptic medications that we know are not really immunosuppressant medications. So they continue what they are taking. There may be a need for increasing the dose and to manage short-term breakthrough seizures. But other than that, there's no change. Now, with regard to research, it has been now 6 or 7 months since the start of this pandemic, and a lot of studies are being done, and we are waiting for, a lot published already, and we are waiting for a lot more. So I do recommend, especially in Sudan, to do research in this disease. First, we, as an African country and with different genetic makeup, the presentation may be different, and there may be some information that are quite useful. I would highly recommend doing retrospective studies. They may not be, the funds or the manpower to do prospective study, but retrospective studies basically students and young doctors just go back and review the charts of patients who are positive for COVID-19 and see the clinical presentation, if it's different or similar to the literature. Regardless, this should be reported in that part of the world, how people present with COVID-19. Imaging findings are also important. Brain imaging in particular, I'm sure there are only very few cases reported, and there is a need to have more imaging findings. Another interesting point is vitamin D level. Here in the United States, the mortality or the morbidity is worse in African Americans and compared to white Americans. And there is some evidence that this could be related to low vitamin D levels. Africans or dark-skinned people are more prone to developing vitamin D deficiency as they actually make the vitamin from the sun, and moving to temperate climates, doesn't have to be Europe or America. Even in the Gulf area, they may be indoors air-conditioned buildings and so on with little exposure to the sun. And vitamin D deficiency is theoretically linked to worse prognosis in COVID-19. So it would be pretty useful to see if how people do in Sudan. Most people will have hopefully a normal vitamin D level, but to see if those who actually do worse than others, whether they have vitamin D deficiency for whatever reason. So if there is a way, I think measuring vitamin D deficiency or measuring vitamin D in COVID-19 would be a very useful project. I would also highly recommend doing local trials, especially of hydroxychloroquine. This drug, there are a few trials. Some of them were actually retracted from both the Lancet and New England Journal of Medicine, which is very rare occurrence, that these trials were not solid enough. Both showed that hydroxychloroquine doesn't work and does not prevent the infection. But with the retraction of these studies, we don't really know. Hydroxychloroquine can calm down the immune system, and it may prevent the cytokine storm and other reactions. So we don't really know. If patients in Sudan, if some of them had hydroxychloroquine, this can be determined by a retrospective study as well, or starting an actual prospective trial. I have heard about using ozone. This is a very toxic substance or gas, and we should stay away from this completely. Of course, and then using garad and so on. These are not any things that that we should subject us the patients to. I would also highly recommend participating in international trials. There are a few antivirals now that are being tried, and vaccines, and I highly recommend that Sudan should participate in this. عن المسؤولين في الوزارة أو جامعة الخرطوم كلية الطب and other جامعات الأخرى مفروض يكون عندهم قنوات للتواصل مع الناس اللي بيعملوا الترايلز دي، لأنه إنتاج اللقاح حيكون بسرعة طبعا، لكن ما حيكون سريع لدرجة إنه كل الناس في العالم حياخدوا اللقاح. فإذا أنت أصلا شاركت في التجربة السريرية حيكون عندك اتصال مع الشركات، واحتمال السوداني يقل يعني ياخذ to get the vaccine earlier than others. So it's very important to participate. بالنسبة للقاح, it's almost guaranteed that these vaccines are safe. So حيكون في إشاعات إنه اللقاح مضر وكده زي ما بيحصل غالبا في أفريقيا والشرق الأوسط. لكن in the case of COVID-19, the vaccines are almost guaranteed to be safe. The question is whether they are effective or not. So it's not a matter of that. So they are very unlikely to harm, but whether they are effective or not, that's the main question. I will stop here, and Nuha, if there are any questions.
There are no questions, Prof. No questions, Professor.
Okay. Yeah, well, thank you very much.